Good
Akshay,
morning, sir.
okay, we'll start it. We'll start on time. It's my great pleasure to welcome you all to this 13th meeting of the Forum of Clinical Neurology. We are stepping into the second year. We started last year in April, following the Tamil New Year's Day, and we have stepped into the second year. I'm very pleased to say that it's been receiving a good response, and I am thankful to all the presenters and the participants for the same. Today, it's my privilege, in fact, to have Professor Sunil Narayan as the chairperson for this meeting. Professor Sunil, as all of you know, was the first professor of neurology at JIPMER, and he's at present professor in the senior scale rank at JIPMER itself. He is also received the award from JIPMER for his scientific contributions. He is the chairman of the subsection of stroke in the Indian Academy of Neurology, and he is the president of TAN, and I welcome him most heartily. He's a dear friend and he's a scholar in neurology as well. Sunil, I think you qualified from Sri Chitra, is it?
Yes.
And he qualified from Sri Chitra Trivandrum. And I'll hand over to Sunil to conduct the proceedings further. And I should thank the faculty of Sri Ramchandra who have come forward to present the cases. And Sundar, a hearty welcome to you. Over to Sunil for continuing this program. Thank you, Sunil.
Thank you, Professor Natarajan, for that very kind and affectionate introduction. Professor Natarajan has been taking lead in this very useful academic forum for the neurology students and also the neurology aspirants of general medicine, MD, and pediatrics. That's what I heard, that they are also given access to this. And this particular special forum, in the days of lectures and lectures of webinars and academics, where the student is the focus, stands out as a special webinar, and also because of its uniqueness that it focuses on clinical case discussion, which is very, very important for the training of the DM neurology students, and also for the medicine and pediatric students to understand their patients and to treat them better, and also to perform better in the examinations. This is the 13th webinar, and it has become quite a popular forum. I see the posters of this often displayed in the notice boards of our department and also other parts. So it's really gathering momentum, and I'm sure that it can grow. It's going to grow further. And as I see the numbers, we started with 5, 15, 20. Now it has already crossed 20. I'm sure that people will be trickling in. So without much ado, I now Professor Natarajan, I also have to tell you that as I have felt the vibration, he is one of the most popular and beloved teachers in Tamil Nadu. And the way the others talk about him, the way the facial expressions change, gets me a real pulse of how he's loved and respected. So it's indeed a great honor to be invited to chair this session. And we have today 2 cases being presented from the Ramachandra Medical College students, Dr. Uma Ravishankar and Dr. Akshay Deepak. And the session is going to be moderated by Dr. Sundar, who also doesn't need any introduction. He is a professor of neurology at Sri Ramachandra Medical College and Research Institute in Chennai, and he's a dear friend of mine. And we would now, without much ado, I would now request Dr. Uma Ravishankar to start the presentation. And this will be moderated by Dr. Sundar. Uma Shankar is a postgraduate resident at the Ramachandra Medical College. And she is going to discuss with you a case of headache. Dr. Uma, please.
Yes. Good morning to one of us here today. I'm going to discuss an interesting case of headache that presented to our institution. So this is the history of a 25-year-old female who had no prior comorbids, an uneventful antenatal period, who presented at 37 weeks of gestation to her obstetrician with history of intermittent episodes of headache for about 5 days. The headache she described was bitemporal. It was throbbing in nature. Each episode lasted around 5 to 10 minutes. It was mild to moderate in intensity, and it was not associated with photophobia, phonophobia, nausea, or vomiting. There was no history of diplopia, vomiting, diminution of vision, loss of consciousness, weakness, or seizure, or abdominal pain. She gave no prior history of significant, recurring, or chronic headache. Examination of the obstetricians revealed elevated blood pressure of 150/90 with an otherwise unremarkable neurological examination and was started on antihypertensives. Patient was taken up for an elective lower segment cesarean section under spinal anesthesia the following day in view of twin gestation, and she delivered 2 healthy baby boys. 3 hours after the procedure, she experienced pain in the central portion of the head that spread holocranially for the next 10 to 15 minutes. The severity of the pain was initially mild, but it became severe over the next 20 to 30 minutes. It was a dull aching type of headache. Patient's BP was found to be normal throughout the course of the headache. The headache persisted despite multiple analgesics. She had no history of photophobia or phonophobia, but she had 5 to 6 episodes of non-projectile vomiting. There was no history of diplopia, blurring, or loss of consciousness. There was no history of diminution of vision or eye pain. There was no history of redness or tearing of eyes. There was no postural change or aggravation of headache on bending or on coughing. There was no history of increased sweating. However, she complained of increased severity of headache in the morning. There was no associated neck pain, no history of fever or altered behavior, no history of recent trauma. Associated with this headache, also reported 5 to 6 episodes of left upper limb and left facial numbness with occasional slurred speech lasting around 10 minutes with complete recovery of symptoms. One of these episodes was characterized by right upper limb weakness, wherein she had difficulty in drying herself with the towel. She was aware of these episodes. There was no evidence of tonic or clonic movements. There was no incontinence or uprolling of eyes. Her headache was near continuous and it progressed in severity. So in summary, this is a history of a 25-year-old female with recently diagnosed hypertension who developed headache 3 hours post LSCS that spread holocranially, increased in intensity over 15 to 30 minutes, associated with vomiting, and also 5 to 6 episodes of left upper limb and left facial numbness with occasional slurred speech and 1 episode of right upper limb weakness. So at this point, what differentials would you like to consider?
Audience, please give your comments. Postgraduate students, we want very active participation of the students because this is for you. Please, there is nothing like a bad comment or so don't be shy. This is your forum. Please discuss freely. So who is going to take lead?
Sir, my name is Shravya, sir. Shall I?
Yes, please. You are from which college?
I'm from Ramchandra only, sir.
All right. Okay. So give us your views on the differential.
Do you know about the patient, Shravya? Do you know about the patient's problem?
Yes, sir.
Then probably you can wait. See, since you know about the problem, you will bias the discussion.
Yes. Yeah, you can wait for a while. Let us see whether others.
till the time others get in to join and express their views. Okay, the setting is that she was found to be a hypertensive. She is in pregnancy. She was operated for lower segment cesarean section, and the headache followed 3 hours later. So we would have to continue. I mean, focus on the setting per se. And in pregnancy, following a spinal anesthesia, this person has had a headache 3 hours following the procedure. By description, this is not a thunderclap headache. But however, the headache has been increasing in severity. And there is a feeling also that early in the morning, it increases. So probably, I would certainly consider something related to pregnancy. The hypertension per se may not be exactly related, as the blood pressure was not very high. Though for a 25-year-old, it might be considered to be on the higher side. So we would have to consider headaches in the setting of pregnancy and a cesarean section being performed and having undergone spinal anesthesia. In this setting, we would have to consider certain vascular events. Certainly, absolutely, that comes first. And amongst the vascular events, we would have to, in view of the focal neurologic deficit she had on the left side, we would have to consider a venous problem in the first place. It could be a cortical venous involvement or a cerebral venous sinus thrombosis involvement. The other possible differential diagnosis would be preeclampsia setting or a press setting also, which is also possible in this. So in other words, we'll have a broad differential diagnosis of a vascular involvement occurring in pregnancy, and the spinal anesthesia may be red herring, and in view of the focal deficit. If it was not for the focal deficit, we could still consider a low pressure intracranial hypotension. But in view of the neurologic deficit, it looks more like a vascular event. So any of these vascular events, a venous involvement or possibly a vasculitis, we would have to consider reversible vascular syndromes as well, and a press. RCVS, press, venous thrombosis in the first place, and the rest as a differential diagnosis will be what I would offer at this stage.
See, the vascular event is again very interesting. These are 6 episodes of TIAs, one after another, 6 episodes. So that also makes it may give some clues as to among these differential diagnoses, which Professor Nararajan very succinctly summarized. To further go, I think this repeated episodes of TIAs with hemiparesis and the speech problems, that will be further helpful.
That would probably favor a reversible vasoconstrictor syndrome, possibly.
Yes, I think.
Or a Carl Fleming syndrome.
Right. So from the venous, we would perhaps go into the venous in this particular context may come probably a little lower than press and other arterial problems. So I think we would like the students to chip in. So anybody other than Shreya to make the comments. So
Shravya, perhaps now you can step in since nobody else is up.
Yes.
Thank you, sir. The only thing I would like to add, apart from what Natarajan sir has told, is post-dural spinal puncture headache, like low pressure headache, could also be one possibility. As sir added low pressure headache, but as the history was telling priorly during antenatal, that is prior to the peripartum also, she had history of headache. So RCVS will be the first differential, followed by low pressure headache. And the other differentials we can consider are any infective causes which will cause increased intracranial pressure.
Shravya, in a low pressure hydrocephalus, how do you explain these episodes of weakness, limb weakness?
Unlikely, sir.
Yeah, that's why it goes low down in the DD.
Yes.
Any other comments?
Sir, Justin, sir.
Yes, sir. You, Vijay and Meghand and all. Yes, please.
Yes, sir. Sir, as pointed out by you, sir, the differential, it is a vascular event, as there is no doubt about that. It started prior to the LSCS, and after LSCS also, he is having a headache, persistent headache. First, we have to think, as you possibly, you have already told it, first possibility you have to think of a vascular. First possibility is, are we dealing with the RCVS? But the thing is, there is no thunderclap headache. The characteristic feature is not present. Even though it's there, even though it is not there, you have to consider this. And the second, possibly press and atypical presses also. And third is, as you mentioned, it is a venous thrombosis, but venous thrombosis in a later set, because he is intermittent comes and goes up. That is like a TAA present, the weakness present intermittently. So are we doing a rare possibility of primary CNS vasculitis, atypical primary CNS vasculitis? Also, we have to think in terms of that, because it has involved the cortical areas where the speech disturbances is present. And one time they got a left upper and lower limb weakness. Another time he got a right upper and lower limb weakness with speech disturbances. So these are the possibilities. Post-dural puncture headache is characteristically, when he already mentioned, when lying down, there is no postural changes. If it is post-dural puncture headache, if he lies down, definitely you will have a relief over there. So that possibility is a remote possibility, sir. Thank you.
Is there any remote possibility of any post-operative complications like an air embolism or something? Just to think about all the possibilities. It's more commonly in upper thoracic surgeries and situations of trauma and bone fractures, etc. But because of this recurrent TIAs, and immediately in the post-op background, so we'll keep peripherally in the background, that also. Any cardiac causes, any nothing prevents a young lady from a with a mild with some hypertension to prevent them from having a rheumatic heart disease. It's a very common situation, common problem in our area. So the cardiac embolism, etc., can sometimes start presenting in the post-operative scenario, so also for the first time. So we'll keep options wide, though we would consider certainly the most important problems in the immediate post-operative postpartum scenario will be the consideration in considering the first differential, first of the differentials. Right.
Ramakrishnan, sir.
Yes, sir. Yes, Rama.
Sir, my thought process is also like what you said, sir. One first possibility, it looks like RCVS, sir. Second, venous, in fact, they can have venous TAAs also, sir. So he's having involvement of both sides. But for a CVT, it looks, the headache and the presentation looks little atypical, sir. It is very, the headache is immediately, it has come after the surgery, and these events are very too frequent. So the first possibility looks like RCVS on that from the history and from the history, sir.
So the thunderclap headache absence also probably rule out any post delivery aneurysmal rupture or subarachnoid hemorrhage. That kind of conditions also are quite unlikely because it's a mild. And the persistent headache, we have to think of these conditions also in mind, just to think broadly at these stages, to keep an open mind. But of course, the commonest possibilities, I would consider at this stage as probably press. That will be the first thing I will consider. But all the other possibilities we discussed, I may not keep the lumbar puncture alone as the cause because of the obvious TIA. There are some reports of post-LP subarachnoid hemorrhage, etc. But again, subarachnoid producing vasospasm and then TIAs, they are all very remote possibilities. So could we probably listen to the further presentation? Shall we go ahead with the further presentation?
Sir,
Yes.
one thing, sir, whether
Yes,
the
yes.
BP, is there any fluctuation in the BP, sir?
No,
Madam,
sir. No, sir. So
No,
initially-
any nocturnal rise in BP, because
No.
young female always think of other, there is adrenal related disorder.
No, sir. There was no fluctuation in the BP, sir.
Okay, right.
Hello.
Yeah, because pheochromocytoma, young females are nocturnal BP rise, fluctuating BP, that also produces severe headache and persistent headache also. Okay.
Hello.
Yes, sir.
Hello.
Nadesan, sir. Proceed,
Yes,
Nadesan,
sir.
sir.
Good morning,
Please.
Dr. Vivian. I fully appreciate your participation. There are two this thing. Nothing has been mentioned about both the fundi of this thing, optic fundi, as well as the neck rigidity in the postpartum event.
Sir, we are in
Doctor-
the symptom
We
stage,
are in
sir. We
history
are in the
level.
symptom stage. We have not gone to examination yet.
Fine, sir. Fine. The first and foremost, one will like to think is venous thrombosis. All other things are agreed. There are other possibilities. There is premorbid conditions like AVM, meningioma, where they are known to increase in size and cause symptoms during pregnancy. Although they are very low in the list, I think one should consider that also.
Agreed, sir.
Thank you.
So we'll keep an open mind and then listen to the physical examination findings. Then we'll try to narrow down the differentials.
So at this point of time, this headache semiology did not fit into any primary headache phenotype, and she also did not have any prior history of chronic or recurring headache. So we had to consider a secondary headache. When we put it with the history and the associated symptoms, we consider two possibilities. One, could it be a headache associated with a TIA or a headache associated with the seizure? But the problem was the symptoms that she described was a negative sensory symptom, as in numbness. So the possibility of a seizure turned out to be less likely. So these, but still we could not completely rule it out. So this was the differentials that we considered. We thought of a headache with TIA, like we had discussed, the possibility of RCVS was considered, but again, she didn't have history of thunderclap headache. Possibility of vasculitis, either a primary systemic vasculitis or a primary CNS vasculitis was thought of. 2, arterial dissection. 3, any condition of preeclampsia or HELP, though she did not have any like prior in the antenatal period, there was no evidence of a raised BP, and also she did not have any abdominal pain. Autoimmune mediated disorders like SLE or APLA, cardiac causes like a valvular heart disease or any arrhythmia, hematological disease like an underlying sickle cell disease or a thrombotic thrombocytopenic purpura, or a condition called Handle, where headache associated with neurological deficit and lymphocytosis. This was our DD. If we thought of a headache with a seizure, again, it could be a CVT, RCVS, PRESS, preeclampsia or HELP, immune-mediated disorders, and vasculitis. So the examination, she was conscious, oriented, and comfortable at rest. So her pulse was 76 per minute, respiratory rate was 14 per minute regular. BP was, her pulse was regular, regular pulse, normal rate, rhythm, character, volume. BP was 110/80 millimeters of mercury on 2 antihypertensives. She was afebrile with normal saturation. There was no pararectus cyanosis, clubbing lymphadenopathy, or fetal edema. Higher mental function was normal. Visual acuity was 6/6 on both eyes. Pupil bilateral 2 mm reacting to light. There was no relative afferent pupillary defect. Direct right reflex and indirect reflex were normal. Fundus was normal. There was no ptosis. Extraocular movements were full. Facial sensation was normal. There was no facial asymmetry, and lower cranial nerves were normal. There was no wasting, atrophy, or fasciculation. Tone was normal. Power was 5/5 in all 4 limbs. Superficial reflexes were normal, and deep tendon reflexes were intact. Sensation cerebellum was normal. Spine and meninges were normal, and her gait was also normal. So at
So
this,
have you carefully looked for cortical sensations?
yes, sir, it was normal, sir.
What were the cortical sensations you specifically look for?
Graphesthesia, stereognosis, 2-point discrimination, sir.
Okay. So graphesthesia, 2-point discrimination. Yeah. Any other one?
Tactile localization.
Tactile localization, tactile discrimination. What is perceptual rivalry? Perceptual rivalry. That's also another important sensory cortical sign. Anybody else want to tell us, want to add any? Because there were only sensory symptoms in the transient ischemia, in the episodic attacks. So since this is obviously a cerebral problem, we would want to look at the specific cortical sense. So these the sensory phenomena are probably arising from the parietal lobe or parieto-temporal lobe. So anybody wants to, what will be the complete list of sensory cortical signs?
She said something about the reflexes are depressed, something like that. Reflexes.
No, sir. Deep reflexes were not.
You said power is only 2 by 5, is it? Something.
No, power is 5 by 5 in all 4 limbs, sir.
All 4.
Uma,
If you stimulate the simultaneously on both halves of the body at symmetrical points, normally which side you'll be able to appreciate?
Both should be.
Yes, both we should be able to appreciate equally, isn't it, at the same time?
Yes, sir.
So what happens in perceptual rivalry, on the affected side, you won't be able to feel that, and you can, if you touch individually both sides, you will be able to sense, but if you give a challenge by simultaneous stimulation of both the sides, subtle cortical sensory deficits can be brought in. The other thing is position sense is always interpreted, proprioception is finally interpreted at the sensory cortical level. So if you keep one limb in a particular position in the space, and ask the patient with the closed eyes, if you put the limb in one space, especially in one particular position, and ask him to imitate the same with the opposite limb, they are able to perform it. That also shows the intactness of the entire large fiber posterior column medial lemniscus pathway all the way up to the sensory cortex. So that's again another important cortical sensation.
Yes, sir.
Uma,
Yes, sir.
can I say something? Yeah. See, the headache, as you said, is non-specific, but
Yes.
certainly has a vascular flavor.
Yes, sir.
And I would seriously consider in this setting with what you have mentioned as near normal or almost normal neurology on examination, I would consider the differential diagnosis, seriously consider handle as one of the topmost differential diagnosis, namely that of migraine symptoms with neurologic deficit, particularly sensory and headache. I would certainly consider handle and look for lymphocytosis in the CSF.
Yes.
That would probably be a top, one of the top 3 or top 1 in the differential diagnosis to me with this presentation and history and the clinical examination. So what investigations would you like to send? Apart from the MRI, which anyway we would be doing, MRI, MRV, I would certainly like to see the CSF findings and look out for a lymphocytosis.
Yes.
So are you able to get a CSF from the theater, which was used for lumbar puncture, or you subsequently do a lumbar puncture?
Yes, sir. I'm coming to that.
All right, okay. Any other investigations, what are the naturally what will be the common investigations you will do at this phase?
Shall I?
Yeah,
Shall I
I'm seeing only apart from Shravya, the other postgraduate students are not chipping in. This is a simple question. What investigation would you like to send at this stage? We have got the history and the physical findings.
Obviously, anybody would do an MRA, MRV first, even without
Yes.
us saying so. It would be
So
MRA, MRA, MRV, all the MRs will be done.
Yes. Okay, I think that's why they are shy to say that. Right. Okay. So go ahead. I think you can go ahead.
Yes. So this was a routine investigation, sir. She had a mild microcytic anemia, which was normal. It showed an iron deficiency pattern, though it was a normocytic normochromic blood picture on here. Total counts was 12,390. Platelet was 4.46 lakhs. PT-PTT INR was normal. RFT and electrolytes were normal.
Right. What is the MCV? 88.
NCV is 0.1, sir.
What is the normal MCV? You said microcytic.
Yes, sir. Normally it should be less than 80 to call it microcytic, sir. But this is a normocytic.
88.1. So why do you want to say microcytic? They also reported peripheral smear as normal, isn't it? Okay.
Yes. So RFT, LFT, electrolytes was all normal, sir. ECG was normal, echo was normal, and chest X-ray was also normal, sir.
Uma, one other finding, she did not have any neck stiffness, no?
No, sir.
Okay, thanks.
So next we proceeded with an MRI brain, which showed symmetrical frequent flare hyperintensities in bilateral periventricular region and deep subcortical matter of bilateral frontal parietal temporal lobes. And these lesions were perpendicular in orientation to the lateral ventricle. There was no contrast enhancement, and there were scattered areas of patchy focal diffusion restriction in the right corona radiata, right lentiform nucleus, left frontal and parietal lobes with no abnormal contrast enhancement. So in this, we see T2 flare. This is a sagittal view of T2 flare. In T2 flare, we see that there are T2 hyperintensities, ovoid in shape, perpendicular to the lateral ventricle, just adjacent to the callosum. This is there in the frontal, parietal, and temporal lobes. Here we see symmetrical areas of patchy T2 flare hyperintensities seen as described. And here we see an area of patchy diffusion restriction in this area. This is a diffusion cut.
Uma, in your opinion, what about these lesions, timing of these lesions from the MR image appearance? What would you say?
Sir, these lesions, the sagittal, those periventricular.
Whenever you say lesions, you describe what is the size, shape, distribution, etc. And also, of course, what is the sequences in which they are seen, and how they change with the different sequences. And also, you must tell, in your opinion, what is the whether they are acute or subacute or chronic lesions. So that impression should also be coming out of your observations of the images.
This is a sagittal section, sir, showing a T2 flare sequence. In this, these lesions are ovoid and they are oriented perpendicular, just above the callosum, oriented perpendicular to the ventricle. Timing of the lesion, it is not acute, sir, because these lesions are not showing diffusion restriction. So probably subacute to chronic lesions, sir.
Contrast enhancement?
No, sir, no contrast enhancement.
That's important.
They all appear to be of the same age or different ages.
With this, sir, in this, there is one area of diffusion restriction, sir. So these lesions, since they do not show any diffusion restriction, I would say they all appear to be of the same age. But there is another lesion which is showing a diffusion restriction, and these lesions do not show diffusion restriction. So probably of two different ages is one possibility we should consider.
Which one is that? Another lesion you told?
The left parietal. Yeah.
Okay. So it is hyperintense in all sequences, or what about the other sequences?
It is hyperintense only in T2 and T2 flares, sir. In T1, it is not showing hyperintensity.
T1 it is hypo.
Yes.
What about the GRE sequence, madam?
GRE, there was no blooming seen on GRE, sir.
What about the venous phase? Venous vessels are normal.
Yes, sir. MRA, MRV normal, sir.
No. The perfusion, we can see if it is a handle, you can see the hypo intensity of the vessels of venous vessels in the GRE sequence. If it is there, it is the area involved, whether the right hemisphere or left hemisphere, it depends on the TAA. It is there.
No,
Because this is mimic, if you see the Sag, it looks like a Dawson, but it is not. There are mimics of Dawsons are there.
Yes, sir.
Do you want to tell what are the
GRE, there was no blooming on GRE, sir. And there was no vessel abnormality seen, sir.
Do you want to tell us what all conditions you can get this Dawson's fingers appearance?
Can you explain the symptoms of the lesions?
We could get it in lesions like leukodystrophy or Fabry, sir.
Leukodystrophy is usually a little different, no? More symmetrical.
This is vertically oriented.
Yeah. They will be maximally in the semi-ovale and corona radiata, symmetrical, radiating horizontally, and of course diagonally, vertically also. But here it's most predominant that radial distribution is from the top of the corpus callosum, isn't it? Vertically upwards. Right. Okay.
I think we've any further investigations?
CSF.
There are no lesions in the posterior fossa, is it?
Yes.
Or do you have
no lesions, sir.
Right.
No, sir.
With the fundi being normal and no definite symptoms of ICT, I think we can go ahead and have a CSF done.
Yes, sir. Differentials at this point.
With that MRI appearance, certainly, but for that one diffusion restriction lesion, so whether the clinical picture fits or not, you would have to consider demyelinating disorder with that MRI appearance, particularly that classical features. But what MRI, what demyelinating lesion in this present setting? Obviously, we will have to consider MS with that presentation, but we don't have any history. It's the first episode, no episodes. It's not an episodic problem. So it's a bit difficult to say, difficult to even think of demyelinating. That's why in the first place we did not. But that MRI appearance certainly raises that, though not classical. So if at all, it's atypical. But as I said, as Justin also pointed out, we can have diffusion restriction abnormalities on MRI in handle also. So that would still remain. But though I'm not aware of this classical periventricular lesions in that, I'm not at all aware. After all, as you know, handle is a very rare entity and entity which is being even questioned. So I do not know the MRI appearance in that condition. But so we stick with our earlier diagnostic considerations, irrespective of the MRI findings. Only thing it adds this possibly a demyelinating disease. This is what I would think.
It's interesting. Uma was also mentioning that in Fabry's disease also you can have this. So did you read much more about it, Dr. Uma?
Yes, sir. But the point against Fabry's disease is that
what is the imaging finding, which is what is the point in favor before you go into against?
is In Fabry's also we get periventricular T2 hyperintensity, sir. But I think the subcortical U fibers would be spec.
Vascular.
That is a image-based diagnosis. Does the clinical picture fit in with the Fabry's?
No, sir. Clinically, it's not fitting into Fabry's, sir.
Yeah.
Clinically, history-wise, we'll suspect a multi-system involvement, sir, like vision disturbance or abdomen pain or any neuropathy like features or renal problem. None of it she
Small
has.
fiber neuropathies, usually more.
So that's only a differential diagnosis on the image. That's all.
Yes.
Image.
Yes, sir.
Proceed.
Just as we have.
Unless there is some comment from anybody else.
Yes.
Ramakrishnan, you want to comment? Nadesan, Meghandan, anybody, sir? Anybody else? Balaji is there.
Can we take the?
Sir, good morning, sir.
Dr.
Should
Jayanti
we,
is there. Yes, Balaji.
sir, should we consider a vasculitis at this stage, sir, with the involvement of small vessels, which could reflect the Dawson finger-like appearance, and with the headache and transient neurological deficits? I would just to.
Yes, Balaji. Vasculitis would be on the card, but again, what sort of vasculitis? Primarily showing up during the pregnancy. The image appearance is could be a differential, could be certainly vasculitis. We have seen that. Yes.
Yes, sir.
Yes, and it's also known that some of the vasculitis, pregnancy is a stress, and many of these autoimmune diseases can be precipitated during pregnancy, after labor, etc. Also, first presentation. Okay,
Uma,
Yes, sir.
Uma,
Yes, sir.
I'm not sure. I'm just asking you. It's not classical, but is this MRI appearance consistent with the Susak syndrome?
No, sir. Like they should also have other involvement of eighth nerve.
No. Forget the clinical picture. I'm not talking of the imaging appearance.
See, that
This periventricular sagittal imaging picture, there is no thinning of the corpus callosum as such, but is it consistent with the Susaks?
in that
Yes, sir.
T2 hyperintensity should come, sir, but nature of the T2, I'm not very sure, sir.
Okay, fine. Go ahead.
One more last comment I would want to make. The young person, history of headache, even before the delivery, you are seeing a lot of white matter lesions. There is no family history, but would you TIAs, multiple TIAs, would you also want to completely rule out, or still keep a possibility of the first presentation of CADASIL? Absence of migraine-like headache in the past, family history, these are.
The MRI doesn't seem to be typical of CADASIL, Sunil.
Yes. Only white matter, the classical distribution of the white matter hyperintensities are not there. Uma, do you want to say, where do you see the classical findings in CADASIL?
Classically, it is not looking like that, sir.
Where do you look for it? Classical findings.
Anterior temporal lobe,
Yes.
external capsule.
Okay. Yeah, so they are conspicuous by their absence here. Right.
You are doing very well, Uma. Proceed.
Yes.
So MRV was normal, so CVT was ruled out. RCVS and PRESS was ruled out because she did not have symmetrical T2 hyperintensities in the parieto-occipital region. And CT angiogram of neck and intracranial vessels was normal. Intracranial MRI did not show any abnormal morphology or any aneurysm. So at this point, we thought of CNS vasculitis, autoimmune mediated disorder, or multiple sclerosis. Now for MS, the imaging features fit into a diagnosis of MS. I mean, not typically, but those periventricular vertical lesions raised a possibility of MS. But headache was not an MS defining symptom, and none of these symptoms lasted for more than 24 hours as required by definition, and she had no focal deficit on examination. So further we did ANA, dsDNA, line probe assay, LIA23, CRP, ESR, APLA profile, ANCA, serum angiotensin converting enzyme levels, all of them were normal. Thyroid profile and anti-TPO we sent because we also thought of a possibility of steroid responsive encephalopathy associated with thyroiditis, but that was also normal.
I will ask one question also. Multiple or transient sensory dysesthesias. Is it one of the defining symptoms of MS?
No, sir. At least for us to say MS, the symptoms should last at least for 24 hours. And MS defining syndromes are mainly optic neuritis or transverse myelitis or brainstem syndrome, sir.
Yeah, dysesthesias can occur, but they are usually longer lasting. Yes. Okay.
CSF, we did CSF analysis.
One word, dysesthesias or sensory abnormalities arising from the spinal level, yes.
Yes, sir. CSF analysis showed opening pressure of 18 centimeters of water. There was only one WBC. The sugars was 58 with a corresponding CBG of 89. Protein was 41.9, which was normal. Gram stain culture, gene expert, KOH, ADA, and other infective workup was normal. Oligoclonal bands was negative. MRI spine plane and contrast was normal, and VEP was normal.
APLA is there in the list of?
Yes, sir.
Premium?
APLA profile was negative.
Okay, that's also normal. Fine.
So at this point, reevaluation, what differentials would we like to consider?
Uma, you are making things difficult for us now. Very interesting case.
No, the patient has made it difficult for us.
Yes. Anyway,
What all are left, Uma, now? Tell us what all are left.
Since we had exhaustively evaluated the patient, the only thing left was to go back to history again, because history would be in the final clue. So
please tell us.
We re-examined the history. We found that her mother had a stroke at 45 years of age, but further reports were not available. So in this, though her headache wasn't a classical migrainous type of headache, and she did have T2 hyperintensities in the anterior temporal lobe, though it was not typical of CADASIL. So we considered CADASIL as a possibility, and we sent her for genetic analysis. And it turned out to be positive.
Excellent. Excellent. Sunil, you are there. As a differential diagnosis, you consider a CADASIL.
Yes, yes. And Uma has not given me a tip, I can assure you.
It was a differential, yes.
These dorsal finger-like lesions are also very well described in CADASIL. It's another, even though that is not the defining CADASIL white matter lesion. If you look at the white matter lesions described in CADASIL, the pericallosal vertical lesions are also described. That's also interesting. Yeah. Okay.
It shows cortical thinning. The dorsal. Do you get a picture like this?
Uma, so before, what else, what other investigation you would do? Suppose you don't have this, the genetic analysis available. What other investigation would you do? Would you have done?
Skin biopsy, sir, and we can look electron microscopy for granular eosinophilic or osmophilic material to look for. Basically, CADASIL is a problem of vascular smooth muscle, wherein there is a problem with the extracellular domain of the EGFR gene. So there will be accumulation of this material. We can look for it on electron microscopies.
Where will you take the biopsy if you are suspecting CADASIL?
Skin biopsy, sir, to look for.
Which skin? Usually. What is usually recommended is the axillary skin.
Okay.
Uma, that left parietal diffusion restriction, did it give you a clue to something?
Actually, when we thought of it, sir, it was more like we also considered multiple sclerosis. Maybe the age of the lesion was different, sir. Like one was showing a diffusion restriction and the others were only there on T2 flare. So,
but wasn't it an odd location for MS?
Yes,
that left parietal, I'm saying. Almost it's a subcortical, junction area, possibly.
Usually when you have so many white matter lesions, we usually see lacunes also. Here, none of the white matter lesions appear to be old lacunes. Lacunes are also very, very common usually in CADASIL. Lacunar infarcts. It's one of the CADASIL acronyms. L stands for lacunes.
Uma, did we not get this history of the mother also having the problem earlier? Did we land on it only after going through all these extensive investigations?
Thing is, we asked specifically for headaches, sir. But stroke history, she wasn't very forthcoming, sir. The thing is, more than the patient, her husband was actually a very overbearing type of person, sir. He would never let the patient talk. So the history was given entirely by him. So when we asked for significant family history, he brushed it off aside, saying nothing. So when we retrospectively, when we went and asked the patient specifically, she gave us this history, sir.
So could you expand the family further? Did you go into the how each of the older generations family members died? They had strokes, one generation above.
Yes, sir.
Now, once you get this, you have to do that exercise, isn't it? You want the entire family tree.
Yes, sir. We took a 3-generation detailed family history, sir. There was no consanguinity involved in any of the generations. And we also took a detailed history of the patient's cousins. Only the mother had a history like this, sir. Nobody else had.
Can you explain mother's history again? Mother's history. Mother, what did she have?
She had a right hemiparesis at 45 years of age, sir. But the symptoms recovered. Like with physiotherapy, she improved within 6 months. But since she regained full normal power, they did not give much importance to it, sir.
Probably that was a lacunar.
Hypertensive. She had one episode of no dementing feature, multi-infarct like.
No, sir. No, sir.
So tell us all these symptoms of CADASIL. What all symptoms CADASIL can present? That's important when you take the history.
Yes, sir.
Or the full spectrum of history symptoms possible.
Most commonly, it's a migraine with aura, sir. That is the most common symptom. And so migraine with aura is the most common symptom, sir. The average onset of this symptom is around 30 years of age, but it is known to occur even in adolescence. So it can start anywhere from adolescence up to 50 years of age. And this is the most common symptom. Migraine with aura, it is usually a typical aura which they have, sir, which is mainly sensory, aphasic, or visual. And the aura should have an onset time of at least more than 5 minutes, and it should last only up to 1 hour, sir. It cannot last beyond 1 hour to call it a typical aura. But occasionally, it has been reported that patients with CADASIL are also known to have at least one episode of atypical aura, wherein the aura can be a hemiplegic migraine, basilar symptoms, ophthalmoplegic migraine, and it can have a hyperacute aura, that is onset will be less than 5 minutes and can be an extended prolonged aura of more than 1 hour. This is also known to be described, sir. The second most common symptom they describe is actually executive dysfunction and dementia, sir. Onset is around 40 years of age, probably because of multiple cortical.
It's a subcortical dementia.
Yes, sir.
And predominantly in the frontal executive type of dementia. So it will take some time to develop. Usually by the reach 50s, 60s, they could start by 60s, 70s, if the patient live enough, only then they go into the dementia stage. Most of them get this mild infarct, like the typical one her mother has had. Probably it was a lacunar infarct with very good recovery. That is the classical types of strokes they get. And they keep on accumulating small silent infarcts as well as symptomatic infarcts. And then if they live long enough to the 60s and 70s, then by that time that they become disabled, they can become various quadriplegia and all can develop. Pseudobulbar palsies can develop, or if only they live long enough.
Yes. Strokes are said to occur in at least 85% of patients, sir. The average age of stroke in male is around 51 years and in females around 53 years, sir. Psychiatric disturbances are also very common, and usually it is anxiety, but syndromes like apathy, bipolar disturbance, these have also been described. Pseudobulbar palsy is also known to occur in these patients. And there's also an entity known as acute reversible encephalopathy, sir. And seizures
There's
can
a
occur.
name for it. There's a name for it.
Cadasal encephalopathy, sir.
Yeah, that is now under it's after a man's name. It's called a Ruskin's encephalopathy.
Yes.
Ruskin's encephalopathy. What is the specialty of that encephalopathy? It's usually a brainstem encephalopathy. So they develop actually, they become stuporous for short time, young people, and then they recover. So this is Ruskin's brainstem encephalopathy, well described in Cadasal actually.
Yes. And seizures are also known to occur in around 5 to 10% of the patients, sir.
Yes. Okay.
So next, when we talk about headache in Cadasal, the most common type of headache associated is migraine, sir, in 54.5% of the patients. But our headache did not typically fit into this phenotype, sir. Usually, like I said, it occurs, migraine with aura is the most common, and typical aura is usually sensory visual or aphasic. Atypical aura occurs in 59.3% of the patients with migraine. They experience at least one atypical aura in their lifetime. Other types of headache is episodic tension type headache or a chronic tension type headache. Our patient fit into none of these phenotypes, sir. Secondly, coming to association with pregnancy, women with Cadasal are known to develop complications during pregnancy, but it does not cause any adverse outcome either to the mother or to the fetus. For around 82% of females, the first manifestation of Cadasal that occurs in the peripartum period. And this manifestation is most commonly a hemiparesthesia in 76%, hemiparesis in 36%, aphasia 65%, or visual disturbance in 47%. Next, considering differentiation of Cadasal versus MS, there are case reports showing that both can coexist. So how do we differentiate the three? We can think of history, investigation, imaging, and lab investigation. History-wise, Cadasal will have a positive family history with an autosomal dominant inheritance. There will be episodes of migraine, TIA-like episodes, and rarely seizures will occur. Cognitive decline is known to occur over a long period of time. For multiple sclerosis, they'll have typical MS-defining syndromes like an optic neuritis or transverse myelitis or brainstem syndrome. And these things should last at least for 24 hours. When we look at MRI findings, involvement of the anterior temporal lobe, external capsule is a pathognomonic of Cadasal. They can also have atrophy or presence of microbleed. MS typical lesions like we have described. The MS will have, we should look for dissemination space, time, gadolinium enhancement. This enhancing lesions will not be found in Cadasal. And if we look at the CSF, oligoclonal bands can be present in MS, will not be found in Cadasal. And IgG index will be elevated in MS. That's it.
Thank you, Uma. That was a very good presentation, very clear, and a nice discussion. I can see the influence and the guidance of Sundar here in your presentation. It's a very good presentation. Very well done, Uma.
Thank you, sir.
Very good picking up. Nice picking up. Yes.
Okay.
This patient is in which town in or which city? Are they from Chennai or?
Chennai, sir. They're from Chennai, sir.
How is she doing now? What treatment has been given?
We started her on single antiplatelet and statin, sir. For the headache, we put her on only analgesics, symptomatic analgesics. Since she was a lactating mother, we involved the neonatologist also. So we had also counseled her regarding, like the thing is, it did not fit into a typical migraine type of headache for us to put her on prophylaxis. So right now she's only on paracetamol SOS. And
what treatment is a mother receiving and how is she doing?
She is only on single antiplatelet and statin right now, sir. She has recovered completely.
Oh, she had only one episode of stroke, her mother.
Yes, sir. Yes, sir.
And headaches?
No, sir. No history of headache in the mother.
So it was an episode of stroke. That's all.
Yes, sir.
Has she also tested positive for Notch 3?
No, sir. Like we haven't tested the mother for notch 3, sir. Only the patient.
Yeah, I think it's important to do that to see whether there is a really family label can be given.
We have counseled them, sir. They're yet to come back for follow-ups.
But they should not be pressurized also. That is the
And
genetic
the
diagnosis.
MRI appearance in her, in the mother when she had the stroke, what was their MRI appearance?
We did not get those reports, sir. They've asked them to come with the mother for review. They're still yet to come back, sir.
The reports are also, MRI reports are also not available.
The patient's mother was not seen at our hospital, sir.
Well,
You must
wherever
try
she
to-
might have been seen, since she had a stroke, she would have had an MRI.
I fully agree with Dr. Natarajan.
I'm sorry. How mother does not come to the delivery room when daughter is pregnant and daughter is having so much problem? Why mother has not come at all?
The
Any
thing is,
family problem like?
she delivered initially at an outside hospital, sir. And post-delivery only she came to our hospital. With her, only her husband was present. And like I said, the husband was actually a little overbearing, sir. Like only he was was there. The mother did not come to the hospital at all.
Even then, mother, why I'm asking is that, is she demented? She is not able to.
No, sir, not like that. But
there is something, there is a lacune, not in the brain, a lacune in the history, a lacune in the examination of the mother.
Probably lacune in the brain also. But anyway, it will be nice if you could do an academic MRI, register the patient and do from your institution. You could get an academic MRI done. It will be very important and useful.
Sundar, you can arrange for that, Sundar.
Yes, sir. Yes, sir. Sir, thanks for the opportunity. I would like to. I'm audible, sir.
Yes, sir. You are audible, Sundar. Go ahead.
Sir, I would definitely we will investigate mother also, sir. But this lot of practical difficulties, sir. Practical difficulties are there in SRMC, sir. So anyway, we'll try to arrange for mother also. There is no lacune in history or examination of mother. Probably we ask them to come back and then we'll definitely do, sir. And
even
about
if you did not do a genetic test, just do an MRI.
Yes, definitely.
It can give you important clues.
Okay, sir. But about why we chose this case are because history-wise we thought something. After investigation, we thought something. Finally, it turned out to be a different case. And when we checked with the literature, it fit exactly. Most of them fitted. Cadacil is known to be more in pregnancy, and this Dawson finger-like things also is common, and stroke-like episodes are also common. So everything fitted. So we want to highlight this point that we should also keep that in our DD. And credit should go to Dr. Ritvik, our assistant professor, who only went back to the history and saw the anterior temporal lobe lesion, and then we ordered for the genetic test. And this is a case of Professor Shankar, sir. Since he is unavailable, I am representing him, sir. Thank you, sir.
Thank you, Sundar, for very nice pickup, as Sunil pointed out,
Yes.
and for that interesting case presentation itself.
And I would appreciate Sunil, sir. We did not think till at least 10-15 days, and he caught even one presentation. So he definitely needs a tip, sir.
Good choice. Good choice.
So will you allow them to, Uma, will you allow her to continue her family development? Will you allow her to have more children? For two reasons. And how will you take care of the next labor? Pregnancy.
Actually, she has twin gestation, sir. So technically, she's not planning another family. But suppose it was a single pregnancy, and in case she was planning, the Cadacil is not known to adversely affect the outcome of that pregnancy. But we need to be careful with the medication we give her. It should not be teratogenic.
She developed a
headache.
Various symptoms immediately after her delivery, isn't it? So that is one thing. Then whatever the inheritance in the next offspring, and even this offspring, isn't it? So there are probably it's a mild form of Cadacil running in the family. The mother has also fully recovered. Yeah, but we have to keep all this. So if the mother seems to be having a typical MRI, I think you would probably want to have a genetician also counseling regarding the family. So,
Does this patient have any sibling? And how are they?
Yes, sir. She has a sister, sir. Sister is fine, sir. Sister has 2 children. They are also fine, sir.
Okay, thanks.
What is Karasil?
Cerebral autosomal recessive arteriopathy with subcortical infarcts and leukoencephalopathy, sir. But in that, we will have typical features of alopecia and spondyloarthritis, low back ache, sir.
Spondyloarthrosis is important. Yes.
Okay. There are a few other syndromes like Hearn syndrome and all these are all genetic lesions closely physically. I mean, the presentation may be just like that also. Anyway, I think we had a very good extensive discussion on this case, and probably it's time we move on to the next case. Is that okay, Dr. Nagraj?
Yes, absolutely, absolutely.
No. Right, okay. So let us have the next case from Anand. So thank you, Dr. Uma.
No, and, that's from Akshay.
Akshay, sorry. Akshay.
Sunil.
Akshay Deepak, yes.
Yeah, Sunil Akshay is the son of Deepak Arjundas.
Oh, right. Okay. So interesting. So let us see Akshay's case now.
Good afternoon, sir. My name is Dr. Akshay. I'm a DM. Yes, sir. I'm a neurology resident in Sri Ramachandra Medical College. Thank you for giving me this opportunity to present our case.
I'm just trying to decipher my memories of 2 other voices, which I am familiar with in your voice. Okay, go ahead.
This is a 31-year-old female. She's from Chennai who works in an IT company. She's a right-handed individual and she came with her mother to the hospital. So the informant is her mother and herself. She came with chief complaints of diminution of vision for the last 2 years, right upper limb weakness for 1.5 years, both lower limb weakness for 1.5 years, slurring of speech for 1 year, swaying while walking for 1 year, and memory impairment for the last 6 months. History of retinitis illness. Patient is apparently normal 2 years ago, after which she developed simultaneous diminution of vision in both eyes, which progressed over 1 day. This diminution of vision, she was able to see the central and peripheral fields, but it was blurred as compared to earlier. She was able to appreciate colors. She did not complain of blackening in the center of her vision. She had no history of any photopsias or metamorphopsia. She had no halos in her vision or visual obscurations. She had no painful eye movements. She had no history of redness, watering, or dryness of her eyes. She had no history of headache, vomiting, or pre-syncope. No recent fever or vaccination. And this blurred vision lasted for 1 week, which spontaneously improved to near normal vision. So this is a time frame chart, which I'll show you all the symptoms that she's developed over a period of 2 years, after which she presented to us. So this is at her onset, is when she developed binocular diminution of vision. Around 6 months later, the patient developed right upper limb weakness in the form of difficulty in gripping objects in her right hand, such as a pen and a glass. She also noticed difficulty in mixing rice with the hand. She had spillage of food between her fingers while bringing food to her mouth. This weakness progressed over a few weeks, following which it was static until now. She complained of stiffness in her right upper limb. However, she did not complain of any thinning of limbs, twitching of muscles, or flailness. She was able to reach for objects on a higher shelf and raise her hands above her shoulder without any difficulty. And she had no difficulty with using her left hand. So in this chart, we can see that 6 months after the onset of the binocular diminution of vision, she developed right upper limb distal weakness. Around 2 months later, she developed both lower limb weakness in the form of difficulty in climbing stairs and difficulty in getting up from squatting position. The weakness of both lower limbs started around the same time, but she noticed that her right leg was much weaker than her left leg. She had buckling of knees with a history of 2 falls due to the buckling. And over the next 6 months, she developed worsening of her lower limb weakness in the form of requiring complete support while climbing stairs, and this weakness continues to be asymmetric. After 6 months, she developed aware slippage of her slippers, which occurred occasionally. This slippage of slippers, which occurred occasionally, progressed over the next few weeks to a point where she had to change her slippers to one with a back strap, and this was associated with tripping of toes. She requires support to walk on flat surfaces also now, but she can walk short distances by herself. In association with a weakness of her lower limbs, she complained of tightness of her lower limbs, which has been slowly progressive and slowly progressing until now. She had no sudden involuntary spasms of the legs and no history of thinning of limbs or twitching of muscles. She and her family have noticed that when she walks, her right leg lags behind her left leg and her right leg moves in circumduction. She is unable to get up from sitting position by herself. She is able to turn side to side in bed, and she is able to lift her neck off the bed. So in this chart, we can see that 2 months after the onset of her right upper limb distal weakness, she developed both lower limb proximal and followed by distal weakness, which progressed over 6 months and is still progressing. Patient then developed slurring of speech 1 year ago, that is 1 year after the complaint of the visual complaints. She had irregularly articulatory breaks where she would break her words into parts and talk with an explosive voice. Her speech progressed for a few weeks to a point where her family could not understand what she was saying. She was able to understand what was said to her. She had no history of a strained or strangulated speech, no history of a nasal quality of speech, no history of monotonous or hypophonic speech. She had no word finding difficulty. She was able to read and write. She does not make any grammatical errors and does not replace words while talking. She had no difficulty in naming objects or people, and her speech has been static since then. She has history of tremulousness of limbs while reaching for objects, which worsens on nearing the target and improves after the object is held. This has been there for the last 1 year, which has been static. She has no history of tremulousness of limbs at rest. She also complained of swaying towards both sides while walking, which is progressing for 6 months and has been static since then. Earlier, she could walk short distances, but after the swing, she now requires support to even walk short distances. She has history of smearing of food over the mouth while eating. She has clumsiness while trying to button and unbutton her clothes, and she has no history of any head nodding. So this is 1 year after the onset of her visual complaints. She developed dysarthria, an intention tremor, an ataxia, and dysmetria. She, following this, for the last 6 months, she started developing meals taken earlier in the day. She started misplacing objects at home frequently. However, she was able to pay the bills on time, and she remembered birthdays of family members and important national holidays. And she was able to recollect important family events in the past. She was able to follow TV programs and movies and does not get distracted easily. This memory impairment has been progressive for the last 6 months. She had no loss of interest in daily activities. She did not require any motivation to carry out her activities of daily living. She behaves appropriately in public places. She had no history of any public urination, defecation, or undressing, no history of any binge eating, and she is able to multitask. She does not get lost in familiar places or at home. She is able to recognize familiar faces and buildings. She is able to dress herself normally and manage finances at home. She is able to brush her teeth and comb her hair by herself. She is able to identify all objects without any difficulty, and she is able to differentiate various colors. She is able to smell the food that is cooked at home. After the initial blurred vision, she was able to see clearly, able to read the newspaper and bus numbers. She had no history of any drooping of eyelid or double vision. She was able to feel the hot and cold water over her face with no loss of sensation and no difficulty in chewing food. She had no deviation of angle of mouth or drooling or saliva. She had no history of any hearing loss, no history of any tinnitus or rotatory giddiness. She was able to swallow liquids and solids without any difficulty. She had no history of difficulty in turning her head from side to side or difficulty in shrugging her shoulders, and she was able to maneuver food in her mouth without any difficulty. She had no history of pins or needle sensations, tingling sensation or numbness in her limbs or face. She was able to differentiate hot and cold water over her face and body. She is able to feel the pain of mosquito bites, able to feel the clothes that she is wearing. She is able to feel the firmness of the floor that she walks on. She had no history of unaware slippage of slippers, no history of cotton wool-like sensation while walking, no history of worsening of swaying while washing her face. Her walking difficulty does not worsen in the dark. However, she is usually supported while walking even in the dark. She had no band-like sensation in the trunk and no history of electric shock-like sensation on bending her neck. She was able to feel the fullness of her bladder, able to hold urine till she reaches the appropriate place, able to pass urine freely, and able to completely void urine. She had no history of any abnormal sweating, palpitations, or giddiness on standing up. She had no constitutional symptoms such as fever, cough, chest pain, abdominal pain, or dyspnea. No history of any loose stools or constipation. No history of any headache, trauma, loss of consciousness, or involuntary movements. No history of any weight loss or weight gain. No history of loss of appetite. No history of joint pains or rashes. No history of any recent vaccinations or heavy metal exposure. And no history of any native medication intake. Her past medical history, she's not a known case of diabetes mellitus, hypertension, coronary artery disease, thyroid disorder.
Before you go to that, I must comment that this is one of the very best and exhaustive histories I have ever heard. So congratulations to your mentors and to you, and also probably all those others are also involved in your training. So it has been, it's a very exhaustive, very good history. We'll discuss them later. Please go ahead.
Thank you, sir. She had no surgeries in the past. She has one child with no bad obstetric history. She has a regular menstrual cycle, and she had an uncomplicated pregnancy 3 years ago. She had no similar history in the family, and she was born out of a non-consanguineous marriage. And there's no family member who is affected with any illness. She consumes a mixed diet. She does not consume alcohol or tobacco. She has normal bowel and bladder habits. She has a normal good appetite, and she has a normal sleep pattern. Coming to the history summary, this is a 31-year-old female with no prior comorbidities and no significant family history, who came with an acute onset of binocular diminution.
Married or unmarried?
Married, sir. Married with one child.
I think you must say that also in the first sentence.
Sure, sir. Sure, sir. She came with acute onset of binocular, simultaneous, painless diminution of vision, which improved over 1 week spontaneously, which occurred 2 years ago. 6 months later, she developed right upper limb distal weakness associated with stiffness, which is progressive over a few weeks and now continues to be static. 2 months after the onset of upper limb weakness, she developed bilateral lower limb proximal weakness, which progressed over 6 months to involve bilateral distal lower limb weakness, which was associated with stiffness of the lower limbs, which continues to progress. 6 months later, she developed a scanning and staccato speech, along with dysmetria, ataxia, and an intention tremor, which progressed over a few months and remains static after that. And she developed recent memory impairment over the last 6 months, which is progressing, with no involvement of sensory system, autonomic or extrapyramidal system involvement, and no constitutional symptoms.
Right. Okay, so 1, 2, 3. So memory impairment is the last of the development.
Yes, sir.
3 main sets of symptoms: visual, motor, and memory. The cognitive, it's only memory. All other domains appears to be fairly well preserved, correct?
Yes, sir.
Right. And there is no family history.
There is no family history, sir.
Do you want to, was there any removed possibility of any exposure to toxins of any type?
No, sir. No exposure to any toxins, sir.
I think in the background we have some disturbance. Can
you please mute, sir? Can you please mute your
digital team, please look into it from where the background noise is coming, and please is there any possibility of any what are the circumstances before we go into degenerative conditions and all? So what will be your general way of differentials in this?
So,
I think you grossly tell what is the category of disease that this could belong to and what.
sir, sir.
Sunil, do you want Akshay to discuss or somebody else to discuss?
Yeah. I think it's better. Yeah. I'm not finding many people coming up, so that's why I was a bit discouraged to. Otherwise, instead of I thought let them speak, then we will take comments from the consultants. So if residents are not coming forward, it will be more of discussion between us consultants. So you please chip in and give your valuable input. There is nothing. You don't have to be shy of your all trainees. So you don't lose anything by making a wrong comment or making an incomplete comment. So please be bold enough to come forward with your thoughts. It's for your training.
Hello, sir.
Yes, please.
Can I talk?
Identify yourself and tell, please.
I'm Dr. Shravya, sir.
Oh, Shravya. Okay, you are. Yeah, Ramachandra. Before I give any opportunities again to the colleague residents from Ramachandra, anybody else wants to give any comments? How about students from Institute of Neurology or Stanley or?
Sunil, I'm not sure whether the PGs are in.
Oh, right.
I think most of the people in are only neurologists.
Oh, right. Okay. But we have around 40 persons.
Yes.
I thought
most of them are neurologists only.
I think they are missing a lot. I think there has to be some more propaganda. I think we will take it up. Very interesting cases and excellent clinical material. Okay, right then. So let us see. So I think I will let you give your comments, Shravya, then.
Yes. So the binocular diminution of vision, which occurred over one day, which is simultaneous, I would like to localize it to bilateral occipital lesions, because it is almost, although it is not sudden, it is almost acute in onset. Or the second possibility is bilateral optic neuritis, sir, in view of young age and patient being a female. And then
the progressive disease, you would want to say bilateral optic neuropathy rather than bilateral optic neuritis. Isn't it?
Sorry, sir. Bilateral optic neuropathy. Okay. And the next symptom which she developed is right.
Shravya, 1 minute, Shravya. Sorry. See, did you hear the description of the visual loss? Does that give you a clue? You brought in two areas, anatomical areas. Yes, one is the occipital lobe involvement and the other is the optic nerves involvement.
Yes, sir.
The description which Akshay gave about the vision, does it help you to narrow down that further? Can you go to that symptom? Can you analyze that symptom and come back?
Yes, sir.
Please go to that symptom. Akshay, can you focus on what you said about visual problem?
Yes, sir. She developed simultaneous diminution of vision in both eyes, which progressed over one day, and she was able to see in the central and peripheral fields, but it was blurred as compared to earlier. She was able to appreciate colors. She had no blackening in the center of her vision, no history of any photopsia, metamorphopsias, or halos in her visions or visual obscurations, with no painful eye movements, no redness, watering, or dryness of eyes, no headache, vomiting, or pre-syncope, no recent fever or vaccination. And this blurred vision lasted for 1 week, which spontaneously improved to near normal vision.
Thank you. Thank you. Shravya, does that history help you to differentiate between an occipital lobe lesion and an optic nerves involvement?
Yes, sir. Actually, in optic nerve involvement, we'll have pain while painful eye movements or retroorbital pain, which is not having, sir.
No, apart from that, the description itself, how does it help you?
That is when it is optic neuritis. That's why I told you, don't say bilateral optic neuritis. It could be bilateral optic neuropathy also, in which pain need not be there at all.
Okay, sir.
Degenerative optic neuropathy. So how do you distinguish? Why do you say it is optic neuropathy and not occipital occipital lobe degeneration? How do you differentiate? What are the useful points?
No, she is
and-
not committed to an optic neuropathy as that. I don't
Yeah,
think
yes.
she committed.
So then
Yes,
she has
sir.
to defend it. Yes. Why?
And appreciation of colors also is against optic neuropathy, sir.
Exactly. So why
Yes.
do you see? So what is your contention now? Is it an optic neuropathy or is it an occipital lobe involvement? With this description.
It is more in favor of bilateral occipital lobe lesion because it
That's all.
occurred over one day and it is simultaneously involved both eyes at the same time.
See, those are not the points. What are the crucial points here, as you pointed out?
She was able to appreciate colors.
Appreciating
And-
colors with normal fields,
Fields of-
at least by description, and no blackening in the center of her vision. So these are the points which, based on which you are going to say which area is involved.
Yes.
So your conclusion,
Bilateral occipital lobe, sir.
proceed with the further discussion.
Next symptom is right upper limb distal weakness, sir, which she developed over the next 6 months. And it was associated with stiffness. So this I would localize to anywhere along the left corticospinal tract, sir, from the cortex to the cord.
Continue, don't wait for us.
And then bilateral lower limb proximal weakness associated with bilateral lower limb weakness associated with stiffness. I would like to localize it to cord above the level of L1, sir. And dysarthria, intention tremor, ataxia, and dysmetria, I would like to localize to cerebellum and its connections. And memory impairment, because it's recent memory impairment, more in favor of medial temporal lobe and its connections. This is regarding the localization, sir. Coming to what is the lesion in view of...
There is also there is development of scanning and staccato speech along with the dysmetria, ataxia, intention tremor. So this you attribute to the
cerebellum and its connections.
cerebellum. Okay. And the spasticity has finally developed in all the limbs.
Yes, sir.
Right upper limb, then
Right
both
upper
the
limb
lower
and
limbs.
bilateral lower limbs.
Okay. So where do you want to put the lesion for that?
Ravia,
Yes.
I would like to know your comments on one thing. In the lower limbs, it was proximal weakness. How would you analyze that? In the upper limbs, it's very clear. Okay, it was a distal
Yes.
weakness followed by increased tone.
Yes,
In the
sir.
lower limbs, the proximal weakness preceded the distal weakness.
Correct,
So
sir.
what would be your thoughts on that?
Usually, proximal weakness is more common in myopathies and neuromuscular junction disorders, sir. But it should not be usually associated with stiffness. But over the course of the illness, she developed spasticity according to the history.
The lower limb proximal is not only it's not a feature of myopathy alone.
Yes, sir.
But can it occur in pyramidal weakness also?
Yes,
Again,
sir.
spinal versus cortical pyramidal weakness. In cortical pyramidal weakness, don't you the proximal weakness in the lower limb is not always myopathy, isn't it? You can
Yes.
have UMN weakness also. Right. In the upper limb, it's more distal.
Yes, sir.
Would you like to know something more in the history about this proximal weakness from Akshay? Before you comment, see what happened was she started to buckle,
Yes,
right?
sir.
So it
Yes,
is an
sir.
intermediary weakness.
Yes, sir.
Neither distal nor proximal. We also have an intermediate segment.
Yes, sir.
Okay.
Yes.
So before committing to proximal, he has said it is proximal. But what made him say that it was proximal? Should we not ask him about that?
Correct.
Akshay, why
Yes,
do you
sir.
say
There was also awareness of the slipping of chapels, isn't it?
Yes, sir.
Yes.
Yes, sir.
no, that is distal weakness. I'm asking
Yes,
about
that also
proximal
is
weakness.
there. Yes. Yes.
Akshay,
please
why
go.
did you say proximal
Yes, sir.
weakness?
Difficulty in climbing up stairs, sir. So maybe hip flexor involvement and knee extensor involvement also, sir. To climb upstairs, we need to flex the hip. So she had difficulty in flexing her hip to put her to climb to the next step. So that's why we brought in proximal weakness, lower limb.
Climbing
Hip
up
flexors.
climbing up is due to difficulty in which group of muscles, Akshay?
Hip extensor, sir.
No, it is quads.
Hip flexor as well as
Going-
extensor.
Going down would be the glutei.
Okay.
Going up, you need the quads. Going down, you need the glutei.
Okay.
Okay. Anyway, what he said was buckling and climbing up. They would indicate
sir.
a weakness of the quads.
Yes, sir.
The quads, as I said, could be considered intermediate
Okay.
because it is between the ankle and the hip joint.
Akshay, was there any
Yeah.
flexor or extensor spasms?
No, sir.
No.
Spasms, sir.
Okay, so that is questionable proximal weakness in the lower limb. So anyway, it started with weakness around the knee and then it went on to weakness involving the ankle. Okay. Right. So you continue with your discussion. Sorry, I intruded in between because this is a question which you are likely to face in the exam.
Excuse me, sir. Just a second.
Yeah.
Is there any myotonic jerk, sir?
No, sir. No jerk, sir.
Oh.
And no psychiatric symptoms also, isn't it?
No, sir. No
Hallucinations,
psychiatric symptoms.
delusions, and all right. Okay.
No, sir.
Yeah. So have you finished or do you want Shravi, anything more you want to add?
I would like to tell what is the lesion, sir.
Yes, go ahead.
Coming to my differentials will be coming to her age and patient being a female. First, I would like
First
to
of all, have
Sir.
you localized the lesions?
Yes, sir.
Yeah, what are all the sites or sites?
Bilateral spinal cord above L1, sir. Corticospinal tract above L1 and left corticospinal tract anywhere from the cortex to cord and bilateral occipital lobe.
No, one
And,
minute.
sir.
Why the upper limb alone you have taken to the cortical level or intracranial level? Why can't that also be at the spinal level?
Anywhere till the spinal level.
Sorry?
Anywhere till the spinal level, sir.
No. See, lower limb weakness, you said L1 above.
Yes,
You
sir.
did not say up to what point.
Correct.
Upper limb, you said from cortex to the lower level.
Yes,
My
sir.
question is, are you going to differentiate between the upper limb involvement? You're going to put one area, and for the lower limbs, you're going to choose another area, or all, or in one region.
Different.
Basically, triplegia, no? So we're all
Yes.
thinking of the.
I would like to put different areas.
What are those areas?
Bilateral lower limb proximal weakness, I would like to put above L1, sir.
Above L1 means where? Up to which level? Below what?
Below C5, sir.
Who is answering that?
Sir, good afternoon, sir. Dr. Ashwin here, sir, from SRMC, sir.
Very good. Okay, why should it be C5? What is
Sir,
so
she
special
did-
about C5?
So there is only bilateral proximal weakness and there is no associated breathing difficulty or phrenic nerve involvement, sir.
No, this person has a spastic paraparesis, right?
Yes, sir.
Plus has an involvement of the right upper limb, which is also of an upper motor neuron involvement.
Yes, sir.
Why do you want, so you are saying for the spastic paraparesis, it is above L1 and below C5.
Yes.
I don't know why you chose C5. And which level are you going to choose for the right upper limb UMN involvement? Why are you having so much of problems?
What is this phenomenon called? Right upper limb followed by the lower limb progressing.
Ellsberg, sir.
If it is an Ellsberg, where is the usual lesion?
Cervical cord, sir. High cervical cord.
Akshay also said that the right lower limb is more involved than the left
Yes.
lower.
Left. Yes, sir.
Yeah, that's how it had progressed.
No.
Okay.
So if it is Ellsberg, where do you put the lesion?
High cervical cord, sir.
Is there any other things in this history to suggest it is high cervical?
No. No other history.
So there are definite cerebellar features also, isn't it?
Yes, sir.
So can you consider a high cervical syndrome with cerebellar involvement also?
Yes, sir.
Which is that one?
What is that syndrome?
Arnold-Chiari.
Okay.
Okay. So now you go to think of the next one. Later, the visual problems development, it was initial one. Can ACM be associated with visual involvement also? If so, how?
Demyelinating lesion, sir.
No, we are now talking about a CV junction lesion where there is cerebellar involvement and Ellsberg phenomenon and all. Can it anyway be connected with a visual syndrome also, bilateral visual? Just thinking of possibilities.
Not sure.
Akshay or
no, Shravya, no, Ashwin. The other one was
Ashwin.
Yes, sir.
Ashwin, yes.
See, where would you put in the speech disturbance?
The speech, she has more of a cerebellar speech. So left paravermian regions in the cerebellum.
Was it a cerebellar speech, the way Akshay described? Or was it a spastic dysarthria?
He described cerebellar, sir.
Cerebellar, it was more of scanning.
Okay, right. I missed out on that. You could be right.
He said scanning staccato with the dysmetria, ataxia, and intention tremor.
Yes.
So this much he has put into. So there is so all these together suggest a.
Cervicomedullary was on location.
Yeah.
Now
and
then,
that is the case. How will you associate the visual ones? That's what I was.
And also the memory disturbance.
Yes. Ashwin.
Sir? So the memory disturbance localized to medial temporal lobes. More of recent memory is affected.
Okay.
So,
vision.
So vision is, as we discussed, first is bilateral occipital lobe, and then that's the first DD, sir.
Okay, so putting together all these.
Occipital.
See, within one day, the visual loss develop, acute onset visual loss.
Yes, sir.
So, what are conditions?
And recovered in 1 week's time.
Yeah. Was there any headache any time at all? No.
No, sir. No headache, sir.
Okay, it's a slowly some of the. I think there is. Should we go back to Akshay for his DDs, or anybody else wants to think of conditions where you can put them all together? So suppose we are thinking of
somebody say that this is a systems involvement? Can it be at multiple sites rather than even the limbs involvement and the cerebellar involvement? Can they be at multiple sites rather than being at the cervicomedullary level?
Yes. You have to.
Can there be multiple systems involved here, particularly since we are talking of the occipital lobe and the medial temporal lobe?
Yes.
Can it be spinal cord and cerebellum? 2 sites, spinal cord
Yes,
one, cerebellum another, occipital lobe at another, and probably the medial temporal.
Yes,
So,
sir.
So you are having a multi-system involvement or
Yes, sir.
multi-site involvement.
so this is the fascinating area of medicine. You have to first you have to think of both Occam's razor-based principle and law of parsimony, both.
Yeah.
But you put them all together and localize, which all will be the condition where there are multiple localization and multiple etiologies. Even that is also possible. So if you apply those principles, you should be able to think of all the possibilities.
So now you go to the differential diagnosis.
Yes, sir.
Either
as discussed,
Ashwin or Shravya.
So first,
So the patient is a young female, sir. So if I want to put it in multi-system, sir, in view of medial temporal lobe, occipital lobe, and corticospinal tract involvement. So my first differential will be immune-mediated or inflammatory, sir. In immune-mediated, I would like to consider multiple sclerosis, predominantly primary progressive, sir, because over 1 year span she kept having progression of symptoms, but the points against PPMS are she had rapid visual loss, which is not typical syndrome of multiple sclerosis, and cognitive loss, which is also again a red flag for multiple sclerosis. And the other immune-mediated diseases which I would like to consider are NMO spectrum disorder and MOG, etc.
Shravya, one minute, Shravya.
Sir.
You'll have to be very clear whether it's an occipital lobe or optic nerve involvement. You are discussing conditions where optic nerves are involved. You have forgotten that you localized it to the occipital lobe. All the conditions which you're mentioning, like demyelinating disorders of MSO or NMO and other things, will be optic nerve involvement and not occipital lobe involvement. So you'll have to be very clear as to whether it is an occipital. This is why I asked you initially itself whether it's an occipital lobe involvement or an optic nerve involvement, because your differential diagnosis is going to differ based on that.
Yes, history indicates occipital lobe involvement only, sir.
We are only in the history now.
Yes, sir.
You've not gone to the examination findings.
Yes.
I would also consider probable CNS vasculitis, different infarcts evolving over different times.
Okay.
Or it could be multiple infarcts secondary to endocarditis or TTP, sir.
See, think of the evolution. Is it suggestive of an acute insult, infarcts, demyelinating? Is it suggestive of that?
It
See,
is not.
Some symptoms progressed initially for weeks and then remain static.
Yes.
Some symptoms still is progressive.
So whenever there is a progressive neurological disease, what are the main 2-3 types etiologies you will think of?
Neurodegenerative.
One is degenerative, then?
Yes. And,
what about space occupying? Yes, neoplastic or space occupying. Third, what is the third category? Okay, they are also sort of degenerative.
Infections.
Yes, infections can progress. For example, HIV and so many. Then the others are either toxic or nutritional. They can also be progressive, isn't it? So these are the possibilities. So here you should be thinking of some of these conditions rather than the other acute conditions, isn't it? There is a progressive syndrome happening here.
Yes, sir.
Shravya, only
Yes,
the cerebellar symptoms and the right upper limb weakness
Yes.
is static. It progressed initially and remains static.
Yes,
Whereas
sir.
the lower limb weakness is still progressing. The visual disturbance came on acutely, recovered fairly subacutely itself within a week. The
Yes,
memory impairment is progressing.
Yes.
So there are features in this picture presentation, some of which, most of which had progressed, some of which remain static, some of which are still progressing, and only one reversed, namely vision. So this is how you would have to analyze when you think of pathologies.
So we have a question from I don't know who is it, Zoom user. Can you please unmute yourself and tell? It's an interesting question from one of the audience. The audience name is shown as Zoom user. Who is that?
Hello, sir. I'm Dr. Sankavi from Coimbatore Medical College, sir.
Go
Okay.
ahead, ma'am.
Oh, please.
Sir, I'm just thinking, could it be CV junction anomaly with space occupying lesion like hydrocephalus, which is compressing the medial temporal lobe, as well as we can localize it to
proceed.
the particular. So with all these symptoms, I can localize it to the, I can narrow down the diagnosis, sir.
So you're postulating a cervicomedullary junction with the hydrocephalus.
Yes, sir. Rather than thinking of multiple localization, I want to think it could also be the possible differential diagnosis in this case, sir.
So she's using Occam's razor, single localization.
One approach. But how did the vision improve, Sankavi?
Yeah.
With the hydrocephalus,
okay,
without
sir.
any intervention, how did it improve?
Suppose some of the ACMs and other cervicomedullary junction meningiomas and all can have episodic fluctuations of raised ICP and recovery also, because there are some postural mechanisms also playing into that. But usually that kind of a visual recovery is not very common. But you can have acute hydrocephalic attacks, both ACM and CV junction meningiomas, and that can produce blurring complete blurring of vision and then recoveries and all. Though not very common. That is one way of explaining it. You still want to explain it. Okay. So anyway, that's a good way of thinking. Some of the cerebellar features can also be explained, and you can have to explain the Ellsberg phenomenon there. So good that you thought about it.
Okay.
Okay. So like that, any other interesting suggestion from the audience? Okay.
CV junction with vascular kinking, any vascular lesion which can produce acute onset with recovery, like that.
Yes. So with the associated vascular lesions also, right? Okay. What about if I say it is due to some say vitamin B12 deficiency? Can many of the lesions be many of the symptoms be explained?
But patient doesn't have sensory attacks, sir. Dorsal column involvement, there is no indication according to the history.
Yes, it is usually predominantly a posterior column.
Yes, sir.
Yeah. So you can get spastic involvement also. You can get visual involvement also.
Yes.
But the absence of posterior myelopathy is and sensory involvement is a point strongly against. Okay.
Leukodystrophy is another consideration, sir, but asymmetricity is against it, and improvement of vision is against it. Adrenoleukodystrophy or adrenomyeloneuropathies.
Yes, improvement of vision is a point against it. Yes.
Yes, complicated HSP is again one more differential, sir. But however, her vision improved in SPG 7, SPG 15. They'll have dementia with visual loss, but patient's vision has improved, so that is also against. And asymmetrical presentation is also against.
Okay, so we discussed most of the progressive syndrome and single lesion or single etiology. So if you think of the multifocal lesions, the law of parsimony, multifocal lesions, one of the things she told is a immune-mediated vasculitis.
Yes.
That can explain many of the syndromes. Some lesions can leave behind lesions in and there can be static lesions. Some of them can continue to progress.
Yes.
And there was an interesting possibility of infection-related inflammation producing a progressive multifocal syndrome also. So if you are considering, I think who told about infections? I think that was Yeah, Shreya. So which kind of CNS infection can explain this kind of a progression?
Tuberculosis and HIV, sir, which might present as progressive multifocal leukoencephalopathy or vascular myelopathies.
So they are great mimickers, isn't it? Yeah.
Yes. And any infections that cause chronic meningitis also can cause symptoms like this.
Yes, either due to encephalon and spinal involvement, or also due to secondary vasculitis, isn't it?
Yes. Yes.
Right. So, Professor Nataraj, can we progress to?
Yes, sir, certainly. Yeah, it's time. It's time we
Yeah.
go on.
Yes.
Please.
So, Deepak, do you want to
Akshay,
progress? Yeah.
Akshay, I need to correct myself. I was wrong in one. See, what you had said is correct. That is, while going up the stairs, we use more of the proximal muscles only. Yeah, you're right. That is the hip muscles, gluteus. And only coming down, we use the muscles at the knee, namely the quadriceps and the calf muscles. You are right there. Sorry, it's my mistake. You go ahead with the presentation.
Yes, sir. So after this, as we discussed, bilateral diminution of vision, we considered occipital lobe versus bilateral optic nerve. However,
No, I
due to the
think we
other
have done that. So, actually, for
okay, sir.
want of time, why don't we go ahead with the findings?
Sure, sir.
Yeah.
On general examination, she had a BMI of 21.48, no evidence of any neurocutaneous markers. She had no pallor, rectus clubbing, cyanosis, lymphadenopathy, or pedal edema. She was a right-handed individual with groomed hair, clean teeth, neatly dressed, with no short neck. Her vitals, she had a pulse rate of 80 per minute, blood pressure was 130/70, her respiratory rate, single breath count, was normal, and she was afebrile. She had, coming to a higher mental function evaluation, she had no attention deficit, she had no distractibility. Coming to her speech, she had a scanning and staccato speech. Coming to her fluency, she had an animal naming of 12 in 1 minute. Her fast test was impaired with 30. She had a good normal comprehension, normal repetition, normal naming, and normal reading and writing. Coming to her memory, her immediate memory and working memory were normal. Her recent memory, she was able to tell the date, doctor's name, but she was unable to recollect what she had for breakfast. Her verbal memory, registration, and recall were 4 out of 4. Her visual memory, she was able to identify all 5 objects that were hidden. She had an impaired paired associated learning. She was unable to remember the easy pairs, even 1 out of 2. She was able to remember only 1 out of 2 and unable to remember the hard pairs. And her verbal story for recall, she was unable to repeat the full story, but she was able to list 10 items from the story. So that was also impaired. But her remote memory testing was good. Her frontal lobe evaluation, her FAB was 18 out of 18. Her trail A, she was able to complete the trail A, but the time test was 170 seconds, so she had a slow processing speed. And her trail B was impaired. She was able to complete her conceptual series. Her Stroop test was normal. She was able to interpret proverbs. She had good judgment, insight, and her anti-saccades were normal. She had no release signs. She had no apraxia, no finger agnosia. She had normal right-left orientation. Her calculation was verbal simple and was normal. Verbal complex and written complex, she had mild difficulty in division alone. Others were all normal. She had no hemi-neglect. She was able to copy. She was able to draw. She was able to draw on the map and identify the cities on the map. She had normal cortical sensations. Her occipital testing, her ventral stream, including the ventral stream and dorsal stream, were found to be normal. Her cranial nerve examination, her first cranial nerve was normal. She had normal color vision. Her Snellen chart evaluation was 6/6 in both eyes. Visual field by confrontation method was normal. Her direct and indirect light reflex was present. She had no RAPD. Her fundus examination was normal. Coming to her 3, 4, and 6, she had no ptosis. She had a left eye exotropia and resting position. She had a bilateral adduction restriction with an abducting nystagmus, suggestive of a bilateral INO. She had a mild upbeat nystagmus and upgaze with mild upgaze restriction, and her convergence was impaired. I'll show you a video. So this is on her extraocular movements and informal testing. So you can see that she had an adduction restriction with an abducting nystagmus. This is looking right and up.
And convergence was also normal, no?
Impaired. No, sir. Convergence is impaired, sir. A down gaze is good. She has a mild up gaze restriction with an upbeat nystagmus.
Pupils normal size.
Yes, sir. Pupils are normal size and they're reacting to light with no RAPD, sir.
Anterior segment of the eyes are normal. The iris.
Yes, sir. By fundus. Yes,
No
sir.
synechial,
Iris, sir.
no shallow chamber. Okay.
No, sir.
No circumcorneal injection.
No, sir.
So she has no anterior uveitis.
No, sir. No anterior uveitis.
Why is it important to look for anterior chamber also?
Inflammatory conditions.
Yeah, autoimmune diseases.
Yes.
Coming to a fifth cranial nerve, was a sensation, corneal reflex was normal. A sensation over the face and motor was normal. Her seventh cranial nerve, eighth cranial nerve, 9, 10, 11, and 12 were all normal. Her motor system, she was examined in supine position. She had no fasciculations or atrophy. She had no wasting of limbs with normal bulk. She had spasticity in her right upper limb and both lower limbs. Her left upper limb had a normal tone. Coming to her upper limb power, in her shoulder on the right side, she had mild abduction and extension weakness of 4+/5. Her elbow, she had mild extension more than flexor weakness. And wrist, she had mild extensor weakness of 4-/5 as compared to flexion of 4/5. And her hand grip was 70%. Her small muscles of hand were globally weak at around 70% as compared to her left upper limb. And her left upper limb examination was normal.
Go back. Hand grip is different from the small muscles of hand.
Yes, sir. Small muscles of hand, all were globally weak, sir, as compared to the left side, but minimally weak, sir.
Any wasting?
No wasting, sir.
Okay.
Coming to the lower limb, examination of a hip, she had a hip abduction of on the right side 3/5 and adduction of 4/5, flexion of 3/5 and extension of 4/5, internal rotation of 3/5 and external rotation of 4/5. Her knee flexion was 3/5 and knee extension was 4-/5. She had a right ankle dorsiflexion weakness of 2/5 and plantar flexion was 4/5. Coming to her left lower limb, she had a 4/5 power in her hip globally. Her knee, she had flexion of 4/5 and extension of 4+. And ankle left side dorsiflexion was weaker than plantar flexion, 4- and 4+.
So right is more involved. Right,
yes, sir. Right is more involved. Her superficial reflexes were normal, where corneal and conjunctival were present. Her jaw jock was not exaggerated. Her abdomen reflex was absent, and her plantars were bilateral extensor. All her reflexes were globally exaggerated. However, she had no clonus. Her sensory examination of touch, pain, temperature, vibration, joint position sense were normal. She had no titubation, no trunculate.
Finger flexion and the other signs of upper limb hyperreflexia were there?
Yes, sir. Finger flexors were finger flexor dependent reflexes was present, sir. Was exaggerated, sir.
Okay.
Patient had no titubation, no truncal ataxia. We were unable to perform her tandem walking. She had dysmetria on a finger nose test and finger nose test. She was unable to perform her heel knee test. She had an intention tremor present. She had no rebound phenomena. She had no rhombogism, and she had no dystidokinesia. She had no postural hypotension, no abnormal sweating, and no resting tachycardia. She had no extrapyramidal system involvement, such as normal blink rate, no rest tremor, no bradykinesia, rigidity, abnormal posturing of limbs, or involuntary movements.
What did you
This
say
is a
about
gait.
finger nose coordination? You said cannot.
It was impaired, sir.
Impaired. So
Finger
what
was,
is your
finger was
inference?
impaired.
Is it because of spasticity or cerebellar, or what do you think it's?
On examination, it looked more like a cerebellar dysmetria, sir.
Okay. And tremors were not there.
Intention tremor was present, sir.
Intention tremor was clearly okay.
Yes. This is a gait. She presented us 6 months ago. This is we did not record her gait that time. This is a gait currently. You can see that she's having a significant right lower limb spasticity with the circumduction gait. And her left lower limb is improved a little bit now. She had no signs of meningeal irritation. Her examination of her spine and cranium were normal. Her other system examination, including a cardiovascular, respiratory, abdomen, were all normal.
Akshay, can you go back? Fundus examination was normal, is it?
Was normal, sir.
And no RAPD.
No RAPD, sir.
Okay, thank you. Who is going to discuss?
Shall I discuss, sir?
Yeah, this is Shravya or Sankavi?
Shravya, sir.
Okay.
What about the
Shravya?
person from Coimbatore who had given some comments?
Yes, I think that was Shankavi, I think.
Yes,
Yeah.
sir.
You are there? Shankavi, are you
Yes,
there?
sir. Yes, sir. Yes, sir.
Okay,
Yes, sir.
just one question.
Okay,
What
sir.
do you think? What do you think is the most informative finding? Just answer me that. What is the most informative finding in what he has presented?
There is a spastic type of paraplegia along with distal weakness of the left.
Okay.
Yes.
Shravya, can you tell me what is the most informative finding?
Bilateral INO, sir.
Excellent.
Yes.
So how is it most informative?
It will go more in favor of demyelinating lesions, sir.
No. Okay, that apart. You are talking of pathology now.
Yes, sir.
Apart from
But
that.
according to the history, she never had any symptoms
forget the
suggestive
history.
of...
Forget the history, ma.
Yes,
It's a finding which is bilateral INO. Where does it localize the lesion?
Bilateral MLS lesions.
Where is it?
Midbrain, sir. Brainstem, sir. Midbrain. Hello?
So brain stem.
Yes, sir.
Right?
Yes, sir.
So all the other findings, forget the vision.
Yes.
Do all the other findings sink in with a brainstem lesion? That's all. That one finding will tell you everything.
Yes.
So where do you think is the lesion or predominant lesion?
Brainstem.
So that explains your INO, your pyramidal involvement, your cerebellar involvement, right?
Yes, sir.
What it does not explain is the so-called memory disturbance and the vision disturbance. So now you go back to the vision. So, okay, now apart from, having committed to bilateral INO, what is likely to be the etiology?
Demyelinating, sir.
Sir, please mute your phone, sir. Whoever is talking on the phone, please mute your phone. Ansari, please mute everybody. Okay, so Shravya.
Yes, sir. Yes, sir.
With bilateral INO involvement, what is the most likely pathology?
Demyelinating lesions.
What else?
Any space occupying lesion in the brainstem, sir.
There are only possible bilateral INO. It's either a demyelinating lesion or an ischemic lesion. They are the most likely pathologies to cause bilateral INO. So it is basically a brainstem lesion, and the pathology has to be either demyelinating or vascular. Now you marry that with the visual involvement, and then try to arrive at a diagnosis. Ansari, somebody is disturbing. Can you mute them? Mute everybody, please.
Yes, sir. Yes, sir. We are trying, sir.
Mute everybody.
Yes, sir.
Except the one who is discussing.
Hello, digital. Hello, digital media. Hello.
Can you look at every participant and from where the sound is coming? Please mute that person. We have been requesting many times.
Nadison, sir. Nadison, sir.
Nadison, sir. Sir. Nadison, yes. Dr. Nadison, yes, sir.
Please mute him, please.
Hello.
Please
Hello,
mute him
digital,
for the
please
time.
mute. Hello, digital. Hello, digital.
It's okay.
Shravya, go ahead.
It's been done, please.
So the vision complaint could have been probably bilateral optic neuropathy or optic neuritis, sir. The history.
Please, can you want the digital team to do anything about it? Even Nadation is the sound is coming. Please mute him. He is not muted.
Okay, so what do you think is the diagnosis, Shravya?
Demyelinating
running
lesion
short
is
of time.
Demyelinating lesion is my first diagnosis,
Yeah,
sir.
amongst demyelinating lesions, what is your diagnosis?
Multiple sclerosis, sir.
Okay, anybody having anything else? Any other PGs? Shankavi or Ashwin? Do you consider any other differential diagnosis? Then Sunil, of course, continue. I'm sorry for butting in, Sunil.
No problem. No problem. So, if you are considering so the other systems here gone. Do you want to give your few views first, Trey?
Yes, sir. So as discussed, the localization, sir, we localized to both optic nerves, corticospinal tract up to C5, spinal cord above L1, bilateral MLF, cerebellum, pancerebellar involvement and its connections, along with probable frontal subcortical circuit involvement and medial temporal lobe, sir. So due to this multiple system involvement and young female, we consider demyelination as our first possibility, sir. As Dr. Shravya said that we considered MS as our possibility. We also considered degeneration, but when we went ahead with investigations, which I will show, sir. So her investigation revealed a normal complete blood count, RF, renal function test, liver function test, calcium, phosphorus, magnesium. Her urine routine was normal. Her HbA1c and lipid profiles were normal. Her thyroid function tests were normal. Her ESR, CRP were normal. Her vitamin D was on the low side of 15. Her vitamin B12 was found to be 406, which is normal. Serum angiotensin converting enzyme was normal. Her viral markers were negative. Her serum copper and ceruloplasmin were normal. Vitamin E was normal. Her ECG, chest X-ray were normal. Her ANA, vasculitis panel, and APLA profile were all found to be negative. So this we went ahead with an MRI brain, sir. The MRI brain here we can see this T1 and T2 sections, which can which show multiple oval-shaped lesions in bilateral periventricular, gangliocapsular, bilateral corona radiata, centrum semioval, and left middle cerebellar peduncle and pons. There was no diffusion restriction. However, some of these lesions showed mild contrast enhancement. Then we went ahead and the corpus callosum appeared thinned out. Then we went ahead with the MRI of the spine, sir, which shows in T10, it shows a T2 hyperintensity. And in the cervical cord, we can see multiple patchy hyperintensities in C2, C4, C6, and C7 segments, sir. So this is the MRI picture that we had. We went ahead with the CSF analysis, which shows acellular, showed a high protein. Her infected workup was negative. Her CSF OCB was positive, and her IgG index was elevated. Her CSF NMO was negative. Her serum NMO and MOG were negative, and her IgG4 levels were normal. Her visual evoked potential showed bilateral, was prolonged bilaterally. So we finally diagnosed her with multiple sclerosis, as a progressive multiple sclerosis.
You have not done the other evoked potentials, is the SCP or VAE?
No, sir. We did only VEP, sir.
Okay. What would you expected if you do a VAER in this case, or even SCP? This patient has got bilateral. You had a very clear brainstem sign, isn't it?
Yes, sir.
Internuclear MLF lesions were there. So we can't be very sure, but there is a chance that the VAR would have been abnormal, isn't it?
Abnormal. Yes, sir.
Right. And if it is abnormal, which segment of VAEP? Which waves? Which interval? Okay, you have 1 to 5. So
yes,
probably the 1 to 3, 3 to 5, depending upon where exactly is the MLF lesion. So probably corresponding to that area. Then you have a cervical lesion also, but the posterior column is completely so clinically unaffected. So you might, in the cervical region, you might get a normal SCP propagation, but subsequently, if there is any interruption in the brainstem or the subcortical structure, you would have got, but then there are no clinical signs, sensory signs at all. So we might get a normal SCP also. We won't be very surprised. So anyway, the most important thing is to do VEP. And what does it show? It shows there is a full.
It is prolonged.
It is prolonged. Okay. Bilateral. Is it significantly prolonged? What was the latency?
Yes, sir. Around 120, sir. P100 is around 120, sir.
Both eyes. Okay.
Yes, sir.
So this is what happens. Even the vision recover, even if the RAPD is normal and pupillary reflexes are all normal, you can still have a residual abnormalities of VEP, which is very helpful in making the diagnosis actually. So with this picture of OCB positive and IgG index also you said positive, isn't it?
Yes, sir. Yes, sir.
Okay. So what would be your diagnosis?
I would consider a progressive multiple sclerosis.
Since there is a little bit of time shortage, we would try to go the rest of the discussion very focal. It's already 1:15. Yes. What will be your diagnosis and?
We would like to consider progressive multiple sclerosis, sir. Either a primary or a secondary progressive, sir. Since her visual impairment was there initially, which improved, we could consider this as a secondary progressive multiple sclerosis. But if leaving that and since everything else is progressive, we could also think of a primary progressive multiple sclerosis, sir. So more likely into secondary.
Yeah, I would probably consider a secondary progressive MS because there was a clear interval between the visual loss and the development of the other symptomatology. So I think there is no harm in considering a secondary progressive MS, isn't it?
Yes, sir. Yes, sir.
Right. So the patient now is what is the functional status of the patient? That is the important next important consideration.
Yes, sir. So she presented to us around 2 years after onset, sir, so this segment. So we started, when she came, we gave, after this MRI and CSF picture, we started her on pulse steroids, sir. And following which her right upper limb distal weakness has started to improve, and it has improved to near normal, sir. For both lower limb, when she had proximal weakness, now she has a residual right lower limb spastic weakness, and the left lower limb is around 4/5 with minimal spasticity, sir. Her distal weakness, she still has a residual right lower limb distal weakness. However, left lower limb distal weakness is significantly improving. Her speech and ataxia improved to 90%, but her intention, temporal and dysmetria are still persistent. And her memory impairment is persistent but non-progressive. So right now she is only on, after pulse steroids, we put her on a tapering dose of Vicelone on steroids. She still continued on Vicelone. We're planning to start disease-modifying therapy, sir, but she's still planning her family. So she wanted to wait and then start on disease-modifying therapy, sir.
So the residual weakness is predominantly in the bilateral lower limb. There is significant improvement in the rest of the cerebellar features and the ocular features have improved very well. And the memory is not progressive worsening. Only the motor spasticity and weakness, especially in the lower limbs, that is the only residual lesion now, correct?
Yes. And that too only in the right lower limb. Left has improved.
Left has also improved. Okay. So are you really keen to say at this stage it's a progressive MS?
Since she progressed for 1 year, sir, more than 1 year, so I would still consider a progressive MS. And she's still, right now it is static. We need to wait and see how she's progressing after this to label her, sir.
How common is the recovery in a progressive MS?
Usually not very common, sir. Some symptoms can recover, sir, but usually most of the symptoms will be progressive.
So biologically, all MS are actually progressive. That's what they say, even though it's at a very low level, that's a new concept. But clinically, I think I would try to keep in mind a better kind of a outcome. I would, especially when you are prognostic, because if you say a secondary progressive or MS and all, the moment it's a progressive MS, it's a very bad syndrome which we don't want our patients to have. So this might be wishful thinking, but still that label can be very, very depressing, progressive MS. Whereas a remitting lapsing MS many a time can have fairly good life with the treatment of individual lapses and also a maintenance disease modifying therapy, isn't it? Yeah, so vision has improved. Only the right side is if you take it as a residual non-progressive paralysis at this stage, I would be more comfortable to call and counsel the patient as a RRMS with some sequelae, so that we continue to you are given only pulse steroids as the disease modifying therapy, correct?
Yes, sir. We're waiting to start on MS disease modifying therapy, sir. Once she's willing, we've spoken to her. We're yet to start, sir.
How many months and years now after onset total?
Now 2.5 years since onset of the first vision symptoms. Right now.
What is the current consensus regarding the timing of starting of disease modifying therapy, specific disease modifying therapy?
In RRMS, sir?
Yes.
As to start as early as possible, sir. As soon as we diagnose, as early as possible to start disease modifying therapy.
So especially in this young patient, it's a very strong candidate to still consider to start it as early as possible. And you have a very wide spectrum of drugs available. And what would you consider? Which drug you are planning to consider, and how would you counsel the patient about that?
Since she planning to to continue and have a family, sir, we can consider glatiramer acetate or interferon, sir, because they are safe and until she conceives. So we can plan to start one of these two agents, sir. And we have to decide based on her preference of oral and injectable, and we can decide, sir.
How many children she has? One, no?
She has one child, sir.
Okay, so they are keen to continue the family development plans, is it?
Yes, sir. Yes, sir.
Okay, this you have to carefully discuss with them, with a healthy child, whether they really want to continue. And what are the other options other than parenteral drugs? For multiple sclerosis, what are the other medicine, other drugs available now?
Yes, sir. Oral drugs, sir, and IV and subcutaneous, sir.
Okay, so what are the oral drugs? And suppose we are, suppose this lady, the family has decided not to have any more children and to focus on her treatment. What oral drugs would you preferably start in this patient?
We started on dimethyl fumarate, sir.
Mm-hmm.
And then if at all she's not planning pregnancy at all, and if cost constraints are there, we can even consider teriflunomide, sir, for her.
Right. So teriflunomide is also an important choice if she doesn't want to have any more children. What will be the investigations you will do before starting dimethyl fumarate? Or what are the major adverse effects of dimethyl fumarate?
We need to look at a liver function test, sir, and do a liver function test, and we need to rule out any subtle infections such as any occult TB. We'd like to do a Manto tester and a complete blood count.
That is common for all disease modifying therapies, isn't it?
Yes, sir.
Anything specifically you will check if you want to start DMF? What about the intraocular pressure and cardiac ECG monitoring? Is there any reason why we should do this invariably? Okay, read about the complications and the monitor the prior investigations mandatory for DMF. Okay.
Sure, sir.
So similarly for teriflunomide, the hormonal profile is quite important, isn't it?
Yes, sir.
If you start these drugs, how do you continue to monitor?
We'll monitor them clinically, sir. If they're developing any relapses, then we need to plan to repeat imaging, look for any new lesions, the burden of the lesions, and need to decide whether we need to escalate therapy, sir. And otherwise, if they're doing well, we can repeat an MRI around 6 to 12 months, 6 to 12 months after initiating disease-modifying therapy, and look at the burden on the MRI and see whether we need to escalate therapy, sir.
Okay.
Sir, I've got a small doubt. Early bladder involvement is supposed to be a very conspicuous feature in these cases. How come bladder is so much normal in this case? Bladder is never affected.
Yes, sir. Bladder has always been normal, sir, in spite of so much of cord involvement.
That is very funny because we have seen several cases because early bladder is supposed to be a very, very conspicuous feature in these cases.
Probably if they develop an acute transverse myelopathy, which is quite common in MS and NMO and all, then the bladder involvement is very common. Whereas here it's a slightly slower progression, first in the right upper limb, then in the lower limb, then in the left lower limb. So probably because of that slower progression, and one side usually if the bladder has to be affected, bilateral corticospinal connection to the bladder is affected, to be affected. Probably on the left side, it is paired. I mean, it's because there are only milder corticospinal involvement. That might be one reason why the bladder has escaped.
2 years have gone, sir. 2 years have gone. And they may not even have a pyramidal lesion earlier, but the bladder comes earlier. That is what we have seen most of the time when INO is affected.
Yes.
When patient develops weakness, the lower limb, even before that, the first symptom will be bladder.
Yes.
There's something which is very tricky in this case.
Yes. So the acuteness is something which is associated. That is the only point which I would like to say. The more acute presentation, the bladder involvement is more common, but it's a very, very important feature of multiple sclerosis. No doubt about that. You are fully right. But I think since we started seeing lots and lots of cases nowadays with MRI, all these atypical presentations are also being commonly seen. So it all depends upon how much of the UMN control pathways are affected in the lesion. All about where the demyelinations occur and to what extent are the demyelination and to what extent they are recovering. Probably all these things also. But whenever there is an acute transverse myelopathy, especially complete myelopathies, even in incomplete myelopathies, acute, the bladder involvement is very, very common to various levels. Even if they don't get retention, many a time urgency, precipitancy, so many other bladder symptoms are common. So complete absence of all these symptoms is definitely uncommon. Fully agree with you. And how do you manage the spasticity? Okay, before we go to that, all this, suppose you start on disease money, you have to also think about the long-term immunosuppression, other syndromes, apart from looking for tuberculosis, any recrudescence of tuberculosis. You have to also think of any other opportunistic infections developing generally, isn't it? So all these are important. If it is a progressive MS, as you told, what will be the drugs? What are the drugs available now?
For primary progressive MS, only ocrelizumab is available, is recommended, sir.
What about secondary progressive MS?
For secondary progressive MS, we can give ocrelizumab, sir. We can give rituximab.
If it is secondary or primary, once it is progressive, ocrelizumab is probably the best line of drug. There are some other newer C19 suppressor drugs are also coming up now. So these are helpful drug. But when how late will you wait if you consider so the specific therapies in progressive MS as disease modifying therapy? In other words, what is the cutoff point where you would not give any disease modifying therapies for MS? So the general dictum is once the patient is totally bedridden and no more ambulant or even totally wheelchair bound, then the disease modifying drugs, especially for progressive MS, are not recommended. Because that's not going to be costly. They are not going to be any effective in reversing and all the residual disability of ambulant continued bedridden state and all will persist. So the time to institute any of these therapies are also much earlier. So the moment you have definite suspicion of progression, by what scales do you use to monitor the patient's disabilities?
Is EDSS scale, sir.
Right. So EDSS is one of the important scales, but there are also other scales also, which you know what are the disadvantage, the limitations of EDSS scales compared to other scales? There are some major problems with EDSS scale. It doesn't take into consideration of many domains of in which MS can be affected, isn't it?
Yes, sir.
So especially if you are thinking of the neuronal loss related progressive MS, cognitive disabilities, etc., EDSS may not be a good indicator. So you have to look at the MRI also. You have to look up the other MS scales also, and make a see whether there is a fast progression, and in that case, the disease modifying therapies are quite important. If you are thinking of primary or secondary progressive MS, then the specific drugs are, if they are available, and the patient can afford, or the state can provide, I think the institution is important and helpful. So, and you are all living in an exciting era, because you are going to get so many drugs with lesser and lesser side effect profiles, and even more effective. So that nowadays early diagnosis and early institutional disease modifying therapy is very important. 2.5 years already lost for these patients. I wouldn't hesitate to start a DMD and make my all efforts get these drugs for them through various social support schemes available the patient cannot afford. We have crowdfunding platforms, various ways of getting it, and they should be strongly encouraged to start it. So, any comments from the rest of the faculty or neurology consultants? Professor Nataraj is probably leaving.
No, you covered everything. Everything has been extensively covered. Only thing I'll have to thank you and the presenters and the moderator and the discussions from the audience. And you can close the session, Sunil. It's already 1:30.
Yes. So that was quite a interesting session. Two very nice cases, exam cases, academically interesting cases, and also management-wise also very important, very interesting cases. I hope all of you have benefited and learned at least a few new things. And thank you, Professor Nataraj, for giving me this opportunity also to.
Oh, no, thank you. We have to thank all the presenters, yourself, discussants, and the moderator. Sundar, thank you very much. And thanks, Shankar, on my behalf for agreeing to present us from SRMC.
Yes,
very good cases. Thank you so much.
Thank you, sir. Thank you.
Yes. So so let me conclude by thanking Dr. Ma, Dr. Akshay, and Dr. Sundar, and once again, Professor Nataraj.
Thank you, Sunil. Thank you for making it a great day for all of us. Thank you very much.
Bye then. Have a nice weekend.
Yeah. Thank you.
Thank you.
Thank you, Sun Pharma, for all the arrangements. Thank you very much.
Thank you. Thank you, Mr. Doctor. Thank you, Doctor.
Thank you.
Thank you, sir.
Thank you. Thank all the presenters and the discussants.
Thank you, sir.
Thank you, Sundar. Thank you, Akshay.